Now we'll talk about some of the treatments for Parkinson's. And we have three main forms of treatment. The first is drug therapy. It's the most effective treatment, however, it isn't a cure and there are some complications that can arise, and we'll get into some of these. There are surgical interventions. The challenge here is that not everybody with Parkinson's is a good candidate and it doesn't halt the progression, but deep brain stimulation is working well for some people. And then there's exercise therapy, and this is something that we really advocate for. A routine that's developed in consultation with a physiotherapist and tailored to an individual's ability and environment is something that can help delay the onset of disability and maintain muscular flexibility and strength. Treatment with medication, though it isn't a cure, does control the symptoms and can greatly improve a person's quality of life. If we can't cure Parkinson's, we do at least have the medications that can help, and in long-term care, our goal is just to be sure that people with Parkinson's are as comfortable and as mobile as they can be for as much time of the day as possible. Because the symptoms of Parkinson's are unique to each person, so are the medication regimens. Remember that frequent modification to medication, dosages, amounts, and timing by a prescribing specialist is the best method that we have of symptom control. And this brings me to our main focus, getting medications on time. I acknowledge that this is a difficult request, and I also understand that if a person with Parkinson's has a pill at 6 a.m. at home every day, it simply may not happen at precisely 6 a.m. every day in the facility. But if you have support staff who are planning to start their day with a patient at 7 o'clock, for example, well, that person should have their pills by 6 o'clock or 6:15, or the individual time best suited to them. The ideal for the person is precise and proper timing, and this is something that should be adhered to at all times, but try to think consciously about how medication can affect your interactions as well, and try to time your day so the person with Parkinson's is most functional when you need them to be, times when you want them to be able to move to the best of their ability, like eating, preparing for the day, and things of that nature, so that they can be active in their own care and activities of daily living. There are a wide range of medications that are used to treat Parkinson's, and I won't go too deeply into them. I'll just say that levodopa has been the gold standard in treatment for over 40 years, and it helps to improve muscle rigidity and movement symptoms. Levodopa does so by being converted into dopamine in the brain and stored in the nerve cells to replace dopamine that someone has lost. Essentially, the purpose of the rest of the different classes of medications is in one way or another to increase the effectiveness of levodopa and to make sure that as much of it reaches the brain and is made functional as possible. There are some factors that can interfere with the effectiveness of Parkinson medication. As the condition progresses, the symptoms become harder to manage. Any stress, underlying illness, or infection will aggravate Parkinson's and reduce the positive effects of medication. Constipation and dehydration can both slow down the absorption of meds, and generic drug substitution can sometimes be an issue. A big one is that certain foods and drinks, particularly protein and grapefruit juice, have been known to interfere with the effectiveness of medication. We say that people with Parkinson's must have their medications 1 hour before or 2 hours after eating. And of course, this will continue to come up throughout the presentation, but optimum timing of prescribed dose is essential, and we'll talk about why shortly. Now that we've talked about some things that can affect how well the medication works, we'll talk about a few things that you might notice when it isn't working at its best. About 30% of people with Parkinson's will experience a sudden feeling of being stuck, like in cement, where you're frozen in one spot, unable to move, and no amount of willpower can overcome. Freezing can occur when you're initiating movements, like when you want to get up out of a chair, but it happens a little more frequently when somebody with Parkinson's is already in motion and they're walking in an environment that changes, or they're tired or stressed or in an unfamiliar situation. It's a temporary phenomenon, but the sudden inability to move can be both frightening and frustrating, and it can be dangerous too. It's important to note that when someone starts moving again, they're at risk of something called festination, which is essentially walking up on your tiptoes with a stooped over posture and at an increased speed, which can lead to issues with balance and falls. The next clip that we have is just a quick illustration of what freezing looks like. Now, you'll see here that this gentleman is moving along pretty well until he comes to a change in the tile here, and also a change in his direction, and you'll just see this little hiccup in his step. Now, fortunately for him, he was able to get moving again rather quickly. Sometimes we're talking about people who will be frozen for a lot longer. I do have some suggestions for you to give to the person with Parkinson's while they're dealing with a freezing episode. First, ask them to visualize where they're going and plan their movement ahead of time. If they feel themselves sticking to the ground, just ask them to think consciously about standing tall with their feet apart. Some people do well with a verbal cue, someone walking along with them saying left, right, or clapping to establish a rhythm to step to. As far as physically getting moving again, try having the client shift their weight sideways slowly from foot to foot, or ask them to take a step backwards or to the side, and then once movement is initiated, to try walking forward again. Others do well with a visual cue, so ask them to step over a flat piece of paper on the ground or shine a laser pointer in front of their foot. Any type of visual motivator can be useful. Remember to avoid passive movement, pushing or pulling, because the person is resistant to this and you're only going to increase the likelihood of a fall. Also, remember the possibility of fascination. Be sure to stay in place for a moment to see that the resident is moving safely on their own, and consider making use of mobility aids. Now, I'd like to show you another clip to help illustrate some of what we've been talking about. We're using the writing of the date here as an example, and while it isn't clinical, it does show the differences in symptom control. You can see here that Judy is in good control. Her motor skills are functioning well, and she's able to write clearly. You can also imagine how effective Judy might be at dressing herself at this time, for example, and how she could handle other activities of daily living. Now, we're about to see Judy in an off state, and here she's lost her fine motor control. This is just 2 days later. It's the same time, but she's missed her meds. Again, relating this to other activities of daily living, try to consider the limitations that Judy will face with these things. Imagine asking her to dress herself or to brush her teeth, and imagine the level of care that she's going to require. Many people misinterpret this change in abilities as a choice, as someone intentionally being difficult or demanding. But the reality is, for many, like Judy, there is a huge difference between their ability to control their symptoms in an on state versus that of an off. Additionally, some people find that the effects of their medication doesn't last as long as it used to, so there can be times just before the next dose is due when the effects of the drug wear off and their Parkinson's symptoms return. The difference is that this is a more gradual reduction in symptom control as compared to the on-off phenomenon, which is a pretty quick change. In either case, the patient will require more care with simple activities of daily living that could otherwise be completed with minimal supervision or done independently, and they could be more susceptible to severe complications. I'd like to show one more video to help make another point. Dyskinesias are a side effect of Parkinson medication and not a symptom of the condition itself. They can vary from slightly visible twitches and jerks to extreme writhing or twisting movements. Dyskinesias differ from a tremor in appearance, and also, a tremor is more likely to appear when a person is off. Dyskinesias are caused by having too much drug in the system. The dilemma for a lot of people with Parkinson's is a trade-off between increased dyskinetic episodes and maximum symptom control.